I'm John Guyton, and we're going to be talking about a global think tank on lipoprotein A, an emerging risk factor. In 1963, Kåre Berg in Oslo, Norway, identified by antibody screening in rabbits a serum component that he connected with lipoproteins. And he called this lipoprotein parenthesis, little a, close parenthesis. It's that immunological background that gives us this odd name for a lipoprotein with the lowercase a in parentheses by lipoprotein. So that comes from an immunological background. By about 1970, 1972, Gösta Dahlin and, interestingly, Kurt Furberg, both of whom went on to have careers in laboratory medicine for Dr. Dahlin and for Dr. Furberg, epidemiology, identified a split pre-beta lipoprotein on electrophoresis that was associated with coronary disease, and they began to realize that this was the same lipoprotein that Dr. Berg had found in Oslo about 10 years earlier. And we began to understand that lipoprotein A was a pretty profound risk factor for coronary disease. Skip forward to 1989, Gert Udermann wrote a very memorable paper in Science called The Mysteries of Lipoprotein A. And as we get into our discussion today, I think you'll see that some things still remain mysterious about lipoprotein A. Around 2005, we learned something new about lipoprotein A. We learned that it was associated with oxidized phospholipids, and that most of the oxidized phospholipids in patients with any appreciable amount of lipoprotein A were in this rather minor lipoprotein, at least the lipoprotein that would be generally no more than 25% of the LDL actually being lipoprotein A, but more often it's only 1 to 5% of the LDL that's actually lipoprotein A. So the structure of lipoprotein A is that it's very, very similar to low density lipoprotein. It has a very large extra protein that's wrapped over the lipoprotein, the LDL core of the LPA lipoprotein, and it has repeating motifs in the structure that look like a Danish pastry called a kringle. Think of it as a Danish pretzel. And these kringle factors give lipoprotein A most of its properties. The apolipoprotein A, the protein that makes it the protein that makes it an apolipoprotein, is bound to apolipoprotein B, the core protein of LDL, by a disulfide bridge. So this is an apolipoprotein that is not even really lipid binding itself. The apo-a, it's important to note, is very similar genetically to plasminogen, and it can interfere with the activity of plasminogen so that it interferes with fibrinolysis, because that's what plasminogen generates. Plasmin is the scissors that breaks up clots in the arterial circulation, particularly so that apolipoprotein A and lipoprotein A are actually antifibrinolytic or procoagulant molecules or particles in the arterial circulation and not so much in the venous circulation. So that's about the science that we're going to describe. And now I want to introduce our panelists today, who come from a global think tank, and I'll have them describe that global think tank on lipoprotein A. But let's have the first slide. And I'm John Guyton, and we have Dr. Lisa Mayer, who is a board member of the Preventive Cardiovascular Nurses Association, PCNA, here in the United States. Eduardo Sanchez, MD, MPH. He is the Chief Medical Officer for Prevention of the American Heart Association. Professor Lale Tokazoglu, who is a member of distinguished societies and an MD from Turkey. And she represents the European Atherosclerosis Society, the immediate past president, I believe, of the European Atherosclerosis Society. Then Jamie Underberg, MD, an internist who runs the lipid clinic at New York University Langone Health. And Jamie is representing the National Lipid Association as well with us today. Dr. Sanchez, could you tell us about the global think tank and how that, what the purpose of that organization was, and what we need to, what brings about this discussion about lipoprotein A?
Absolutely, and so pleased to be a part of this. The global think tank, I think, put quite simply, was to bring the perspectives and the participation of a variety of organizations that recognize that lipoprotein A is an important part of assessment and treating patients. And that, but we were speaking with slightly different voices about this, and the idea is to come together and try to align our voices around measurement, around risk assessment, and around therapy.
Great. Well, what are the risks of high lipoprotein A? And I think I want to go to Dr. Mayer to begin that discussion of risks.
Sure. Definitely.
Yeah, go ahead. Go ahead.
Okay. There are risks definitely associated with lipoprotein A. Some of the various risks we talked about during the think tank were specifically the increased risk for cardiovascular disease, the increased risk for aortic valve disease, and then the risk associated with stroke. Specifically, risk of stroke in not only the adult population, but what is the risk of stroke for the children population? What is the risk of stroke for those premenopausal women?
So we don't ordinarily think about children or premenopausal women being at risk at all for stroke, but I guess these events rarely happen. And sometimes lipoprotein A is found in the background, but can someone amplify on the risk associated with atherosclerosis?
Sure, I'm happy to jump in, and others. There's at least a twofold increase with high lipoprotein A. That is a twofold increase in atherosclerosis. So a critically important consideration in trying to assess risk, and again, assess what to do about it in patients.
Yeah, and that would be in the top percentiles, the top 5% or 5 to 10% of the population of LPA levels. And then, Dr. Tokazoglu, could you tell us a little bit more about the aortic valve
Yes, we know that aortic valve stenosis is seen more frequently in patients with high LPA levels. And also, faster progression of aortic valve stenosis has been shown in patients with high LPA in the Astronomer trial. I would like to also add that recent observational data from 2 Danish registries in 70,000 subjects showed that high LPA was an independent predictor of total and cardiovascular mortality, but not non-cardiovascular mortality. The InterHeart study, which is one of the largest cross-sectional studies looking at the risk of myocardial infarction all over the world, showed that LPA concentration above 50 milligrams per deciliter was associated with an increased risk of myocardial infarction, independent of established cardiovascular risk factors. And finally, it's not a risk factor for the first event, but also for recurrent events, as has been demonstrated recently, not only in Danish registries, but also in the 2 large PCSK9 outcome trials, Fourier and Odyssey outcomes, showing that high levels of LPA were associated with an increased risk of recurrent events in patients who already have atherosclerotic vascular disease.
It's a wide-ranging risk factor for cardiovascular disease, and I think you documented that wonderfully. What about the distribution? Who's got high lipoprotein A, and does that differ by ethnicity? And I'll ask Dr. Tokazoglu to introduce us to that topic, and then ask Dr. Underberg also to comment.
The distribution of LPA is skewed in the population towards the left. And we know that 20% or so of the population has LPA levels above 50 milligrams per deciliter. So this is not a small amount we are talking about. The distribution is different, less skewed in Blacks, who also tend to have higher LPA levels. And women usually have slightly higher levels than men. Now, Mendelian randomization studies have clearly shown that genetic variants in the LPA locus regulating LPA levels are robustly associated with coronary heart disease risk in a linear and dose-dependent fashion.
That's great. Dr. Underberg, would you have something to add to that?
That's true, and again, I think that last bit of information is one that's changing, which is what's so interesting about this space. We have for a very long time thought that it was a very binary decision point with lipoprotein A, that once you were above a threshold level, your level was high, and high enough risk was then something to be concerned about. But recent data published suggests that the relationship of risk to cardiovascular disease and some of the other things we've discussed is a linear one. And that linear association of risk is one that is found amongst all of the different ethnicities and between male and female sex. What's also interesting is that the association of risk seems to be greater in those without atherosclerosis than in those with pre-existing disease. The predictive value is greater. And so like everything else, the space continues to change and evolve, and dismissing mild elevations probably is not something that we should be doing anymore.
Yeah, I think one of the things we can say about pre-existing disease is that pre-existing disease itself is a risk factor.
Exactly.
And so the risk associated with lipoprotein A is already incorporated into the risk that we associate with pre-existing disease. So it would make sense that it's not as much of a risk factor. I will tell you an interesting story. Dr. Dahlin came to Baylor in Houston, where I was working, and Dr. Tucker Doglu for a while was there also, and he was looking at a split pre-beta band that I referred to earlier in patients on dialysis. But we all know that African Americans and Black people in general have the ApoL1, which renders them more susceptible to kidney disease. So the dialysis patients were all Black. And I said, Yosta, we should go and look and see if our Black employees in the hospital are different in their lipoprotein A levels than the whites are. And that turned out to be the case. In the Black population, it's actually more of a bell-shaped distribution. And the levels on average are twice as high. If you look at the median levels in Blacks and whites, the median level in Blacks is 3 times as high as it is in whites. With regard to the linear distribution, I've seen a paper recently that says if you have an extremely high LPA level, your risk of atherosclerotic cardiovascular disease may be equivalent to having familial hypercholesterolemia, which is an astonishing thing to me, but that's the implication of that linear relationship of risk. Some people have extremely high levels of lipoprotein A, but most people have very low levels of lipoprotein A. Well, I'll ask Dr. Underberg this question, do people need a certain amount of lipoprotein A circulating in the blood? What is it good for?
Well, since we don't really understand what lipoprotein A does, I would tell you that right now the thinking is that we don't really need it, and having a low level is not something to be concerned about.
Right. Most people have very, very little lipoprotein A circulating in their bloodstream. And we had a surprise in the 1990s that LDL itself, we don't know what the physiological role of LDL is. Exactly. And it might have something to do, there's speculation that in an ancient society where there was a lot more physical trauma, and you had bumps and bruises and cuts all the time, that perhaps wound healing was helped a bit. Not that patients with high lipoprotein A have any better propensity to heal surgical wounds, or it's not something we deal with clinically today at all. But it's thought that there were evolutionary pressures in ancient times that are no longer part of our life today, and that we don't really need these lipoprotein A at all, and most people have very, very little of it. Well, is there agreement? Where are we headed with regard to the measurement? Dr. Sanchez, where are we headed with regard to the measurement of lipoprotein A? I think there's agreement that antibody-based assays are the standard of care. I'll just answer this question myself. That some of the older methods, Dahlin split pre-beta, and the auto profile, which was a density-based measurement of lipoprotein A, those are not considered to be standard of care. But the global think tank came to a conclusion about this, and really putting the standard of measurement on the map as a central issue for discussion today. Dr. Sanchez.
Yeah, there was, I think there's one place where there was some unanimity. Not that there wasn't in others, but this is one where there was quick unanimity. Standard measurement, really important. And concentration, that is nanomoles per liter as the unit of measurement, is the place where the consensus went to. There are global efforts to standardize assays for determination of lipoprotein A levels. That's being led by the World Health Organization. The CDC is involved in the United States, and the Federation of Clinical Chemistry and Laboratory Medicine. So consensus around that. Let's all use the same units of measurement. Let's use a standardized assay. That was felt to be good and really important, not only for clinical care, but also for research and what we're gleaning from the research, so that it could be more immediately applied and thought about in the clinical context.
I will just amplify that and second that. I think a lot of us, I know at my institution at Duke, we're still using a milligrams per deciliter standard measurement. And it's become clear, Dr. Simikas has made this point clearly. Dr. Koszczynski in Toronto, I'm sorry, in I believe in Hamilton, Ontario, have mentioned there, you cannot make a one-for-one comparison between milligrams per deciliter and nanomoles per liter. You can't just convert over mathematically. Although there are some rough calculations, you make mistakes if you try to measure in milligrams per deciliter and then try to convert that, because of the hypervariability of the length of the apolipoprotein A protein. That is an important thing. Then, Dr. Mayer, how can we move forward in implementing this recommendation to standardize the way we measure lipoprotein A?
Yeah, during the roundtable, we talked a lot about this. We talked about how do we make this known? A big key takeaway was just the education to fellow clinicians, the education to patients, the education to laboratory services. We found a big barrier was that the current research, a lot of it is in the milligrams per deciliter. And we talked about the costs associated, with making this change as well. And with that, we talked about the cost barrier in the different testing and conveying the importance to a broad population. In going forward, we looked at the importance of collaborations with different laboratory services in making that standardization. And then also going forward, we looked at the possibility of a group consensus driving that and the payers driving that payment for insurance based payments.
Should we consider specific cut points for various ethnicities to define the risk associated with lipoprotein A? If yes, what would those cut points be? Dr. Sanchez, do you think we're ready for that?
I think we're ready to continue talking about it. And the one thing that was made clear is that in Europe, this may be less of an issue. I wouldn't say not an issue at all, less of an issue than in the United States, as an example, where there is just such tremendous diversity in the population in general. I do think that this was a point of discussion of the think tank. This is an area where we feel like the evidence is emerging, and just as we've talked about, even just weeks to months, there's new observations that we can make. So there probably should be cut points that vary by race, ethnicity. I don't think we're quite ready for prime time with those cut point recommendations.
Yeah, I think we have to be, I would second that, and I think we have to be careful about it. Sometimes you see the reference level of lipoprotein A from the nanomoles per liter in the nanomoles per liter units at 75, but we have to note that that is the 70th percentile of the population. So we're going to be getting concerned about a lot of people. The 80th percentile, or let me just say, if you go on up to 120 nanomoles per liter, I think almost everybody would agree that's an area where you're really giving attention to it and trying to say this person may be at risk. But the question of risk, Dr. Underberg, does everyone with a high or very high LPA level have substantial cardiovascular risk?
So when we're talking about populations, obviously, as lipoprotein A levels increase, a risk for the population that you're looking at goes up. But just like other biomarkers, there are many people who have elevations in lipoprotein A who do not develop atherosclerotic cardiovascular disease or any of the other endpoints that we've been discussing today. And so it needs to be contextualized within the individual patient. And certainly the context of family history is one of the things that often becomes, I think, very important in assessing the importance of elevations in lipoprotein A. And that's something that's actually been highlighted in statements by both the European Atherosclerosis Society and the National Lipid Association.
That's great. I'll ask, should everyone, I'll ask Dr. Mayer and Dr. Tokazoglu about this. Should everyone be screened at least once in their lifetime for elevated lipoprotein A levels? And if you wouldn't mind, is once enough? What are the benefits and costs of that? I don't want to get us in trouble with the United States Preventive Services Task Force. But what are your personal opinions about that? Dr. Mayer first.
Yeah, so just because of the prevalence, approximately 20% of the population is at risk from death of lipoprotein A. I agree with screening. This brings up many different topics. We could talk about cascade screening, the genetic component. Do we go to, if one family member has been screened associated with the increased risk for LPA, do we then continue to screen other family members? We can talk about the non-genetic factors that can also increase LPA, the chronic kidney disease, hypothyroid disease, the postmenopausal women that are at risk. I like the idea personally of screening, because I am someone that if the levels are elevated, I want to do my best that I can as a clinician to help treat and to help raise that awareness of the importance of lipoprotein A.
Dr. Tokazoglu.
I think optimally everyone should be screened at least once in a lifetime for elevated LPA. The high prevalence of elevated LPA, the strength of association with disease, and the potential to improve cardiovascular risk stratification justifies this universal screening approach. Here in Europe, we recommend in our guidelines universal screening, and the recent Canadian guidelines that came up are also agreeing that everyone should be screened. But for some reason, for economic reasons or others, if not feasible, we should at least try to measure it in patients who are likely to have high LPA, like those with premature cardiovascular disease history in the family, those with familial hypercholesterolemia, those who have recurrent events despite statin use, and also if we want to reclassify risk in high or intermediate risk patients.
Right.
That's terrific. Any other comments about that?
I'll just jump in on this and say that I agree with my colleagues. The National Lipid Association statement did not make the leap that my European colleagues have in recommending universal screening. And I think part of it was concerns about cost and also concerns about effective therapeutic options. However, as we've pointed out, because of the importance of this as a risk factor, and we're going to get into therapeutic approaches, it certainly may modify how you address other risk factors. And so I understand why my colleagues did not make the recommendation, but I don't necessarily know that it's not unreasonable to think about screening everyone at least once.
Yeah. And LDL, I'll make the point, LDL rises as people go through the decades of early life. LDL levels are rising from childhood to about age 45 in men. They're rising from childhood to about age 55 in women. But lipoprotein A levels are very constant throughout a person's life. The lipoprotein A level is 80 to 90% genetically determined. It's not subject to much dietary regulation as other lipoproteins are. And so once you have that single measurement of lipoprotein A and it's considered reliable, you can pretty well trust it. Maybe if you're surprised and you say, well, was it the wrong tube of blood? You check it again. But generally, once in a lifetime would be enough. How can we measure? How can we manage patients with elevated lipoprotein A? And I want Dr. Mayer, Dr. Underberg, Dr. Takazoglu, perhaps in that order, to chime in on this one.
Yeah, so I think the ultimate goal that we need to think about is how do we push, first of all, that LDL level lower. With that, and in screening patients, we want to talk about those and screening those with family history of premature atherosclerotic cardiovascular disease. So those males less than age 50, the females less than age, or males greater than age 55, and those females greater than age or less than age 65. We want to talk about those with a primary hypercholesterolemia. So those that in those LDL levels that are initially higher, greater than 160. Those with metabolic syndrome, those with chronic kidney disease, those with those chronic inflammatory conditions, and premature menopause. We can talk about statin therapy and how statin therapy can lower the LDL, but can initially raise the LPA levels. And then talking about more of the newer options, the PCSK9 inhibitors.
All right, Dr. Underberg.
So, again, as I mentioned earlier, I think right now we think of elevated lipoprotein A as a risk factor. And in fact, in the most recent iteration of the multi-society guidelines here in the United States, like colleagues around the world, it's listed as a risk modifying factor. And so when elevated, it means you need to be more aggressive about risk reduction across the board in any patient with elevated lipoprotein A. And obviously, Dr. Mayer mentioned one important component of that is lowering LDL. A caveat that we haven't really discussed here is that many of the agents we use to lower LDL do not lower lipoprotein A. And in fact, a blunted response to LDL lowering with either statins or ezetimibe, and possibly even PCSK9 inhibitors, is a warning sign that lipoprotein A may indeed be elevated if it hasn't been measured in that patient. PCSK9 inhibitors lower lipoprotein A 25 to 30%, depending on which data set you're looking at. And certainly there's some suggestion in post hoc analyses of the two PCSK9 inhibitor outcome trials that the incremental lipoprotein A lowering in the patients in the highest quartiles may provide some additional benefit. But just as important as LDL lowering is addressing things like lifestyle concerns, overweight and obesity, smoking, inactivity, healthy diet management, blood pressure management, management of blood sugar, et cetera. And so it's really an across-the-board alert that we need to address risk aggressively.
Fantastic. Dr. Takazoglu.
I fully agree with my colleagues that we should recommend earlier and more intensive lifestyle and risk factor modification in these patients and try to get to guideline recommended goals for LDL cholesterol and other risk factors as much as we can. Here in Europe, we recently updated the dyslipidemia guidelines and have even more stringent goals for high-risk patients. In secondary very high-risk prevention, in addition to lowering LDL by 50% from baseline, we're also recommending a goal of getting to less than 55 milligrams per deciliter. So if we're unable to do that with statins and ezetimibe, we recommend using PCSK9 inhibitors, who also slightly lower LPA levels. In addition to all this, we know that apheresis can significantly decrease LPA levels, but throughout Europe, they're mostly used to lower LDL in patients with familial hypercholesterolemia. However, in Germany, high LPA and progressive atherosclerosis, despite other medical therapies, is an indication for apheresis, and they have quite a lot of experience there in terms of lowering LPA with apheresis.
That's great. Interestingly, Dr. Moriarty led a group to the FDA, and apheresis, that is lipid apheresis, is now approved in the United States as well when there is persistent and progressive atherosclerotic disease, usually coronary heart disease, and LDL remains above 100 and LPA with the old units above 60 milligrams per deciliter. So that can be an indication for apheresis. And basically that reflects the fact that beyond the PCSK9 inhibitors, some of us still using niacin a bit. Won't get into all of that. But LPA is very hard to move. LPA is very difficult itself to reduce. There are no dietary treatments. There was, interestingly, saturated fat will lower lipoprotein A just a little bit, but it does so many other bad things that we can't use that as a treatment for lipoprotein A. I think that one of the other things that will lower lipoprotein A are the androgenic steroids that the weightlifters use, but that it's terribly high cardiovascular risk. So the options that we have for dealing with lipoprotein A itself are limited, but a new treatment on the horizon. Dr. Underberg, can you tell us about that?
So, like everything else in our lipid space, we're moving ahead at breakneck speed. And it's an exciting time to be a clinical lipidologist. We have actually two treatments in development, perhaps more than that, but I would say two that are more close. One technology that I think many of us are all very familiar with, which is antisense inhibition. This is a small snippet of DNA that finds its way into the cell and creates a duplex strand with the messenger RNA that codes for the production of ApoA, the important component of lipoprotein A. And when this duplex strand is created, an enzyme called RNase identifies this as not appropriate and breaks down the particular component that has been targeted by this antisense component. What's very interesting is these drugs have been tailored so that the antisense DNA is not degraded by RNase, and it can essentially bind to another piece of messenger RNA, and so its ability to exert its effect lasts for several weeks at a time. And it has been modified over time and developed into a more targeted therapeutic with the addition of certain other molecules attached to it, one called GalNAc, which allows it to be directed directly to the liver. And so it can be more effective at lower doses with a better side effect profile. And so one of these drugs called pelacarsen has demonstrated significant efficacy, up to 90% lowering of lipoprotein A in stage 2 trials. And there is now a stage 3 outcome trial going on in patients with pre-existing atherosclerotic cardiovascular disease, looking at lowering lipoprotein A and preventing future cardiovascular events. And that's enrolling now, and it's very exciting. Data suggests that you have to lower lipoprotein A significant amount to see benefit. And so this 80 to 90% reduction that we're seeing with this medication is, I think, appropriate for the way the trial has been designed.
Yeah. You mentioned that it's a modified DNA. It's not something that's going to incorporate into the genome.
Exactly.
Because
it just finds its way to attack the messenger RNA.
Yeah, we don't. Yeah, so it's an oligonucleotide.
Yes. Exactly.
And then there's also, I think you mentioned too, I think you were referring to the small interfering RNA.
Exactly. And the small interfering RNA technology works via a RISC mechanism or RNA-induced silencing complex. And so its effect actually is exerted for even much longer and essentially turns on cellular machinery to target a specific, in this case, messenger RNA component that codes for the protein lipoprotein A or ApoA.
It's the world of RNA biology.
It's fascinating.
That's just revolutionizing a number of fields, but it offers the chance to really. And as you said, we don't need lipoprotein A.
Right.
So 80 to 90% reduction of lipoprotein A, because most people have those very low levels anyway, is not going to be a risk in itself. Dr. Sanchez, what resources would be most beneficial for clinicians in the diagnosis and possibly treatment of patients with elevated lipoprotein A? What do we need in a public health sense, in a sense of organizational resources?
So I'm going to answer this question threefold. I think one audience is going to be clinicians, of course. So guidelines that more clearly call out lipoprotein A would be really useful. With the current science and the ability to update periodically as we are doing, but perhaps also treatment protocols that are embedded in those in that guideline or guidelines. Secondarily, I think guidance at a systems level, both governmental and non-governmental, and what I'm thinking about are organizations, public health organizations. John, I think it's so critically important, Dr. Guyton, I think it's so critically important that we talk about systems guidance that begins to talk about not only the testing itself and the monitoring of testing, but an eye to making sure that disparities in healthcare are continually addressed to close any healthcare disparity. For a number of reasons, one might worry that we would see utilization among some more than utilization among others. And then lastly, some guidance for payers around similar to treatment guidelines that help inform the why around payment for lipoprotein A testing. One of the things that I often say is that guidelines generally inform the what, and we need to be, I think, mindful of the how as we proceed forward for many of the reasons that we talked about before. There's still science emerging. There may not be consensus around a universal screening, and how do we build our understanding of the role and perhaps the importance of universal screening, and then how to track that once in a lifetime test in a systematic way. So I think guidance and guidelines are critically important for helping clinicians, health systems, and payers know what to do and then how to do it.
That's wonderful. Dr. Mayer, what are the potential barriers that you see to implementing the kind of program that Dr. Sanchez has just laid out?
Yeah, he spoke wonderfly to definitely potential barriers that exist. So he spoke, the key is getting a guideline set up, getting a guideline, and then a standard reference system that we can use. And not only that, but just the education. I think education is key in all of this, in getting everyone on board, educating clinicians, educating nurses, educating the hospital staff, administration staff, educating insurance companies. And lastly, educating our patients is going to be so important. The other thing I think that will be very important, or is a potential barrier to change, would be cost. What does the cost look like for implementing a universal screening? What does the cost look like to the patient? And then lastly, just getting on the standardization of the nanomoles per liter going forward.
Right. I want to finish up by asking each of you to focus on one or more points that you think are most important. Let me just say there is a National Lipid Association scientific statement on lipoprotein A that's published in the Journal of Clinical Lipidology, and there's a fantastic 2019 EAS recommendations. EAS, I guess, European Heart Society as well. EHS recommendations where lipoprotein A receives very, very strong attention. As well, Dr. Takasoglu. But I would ask each of you, and we'll start with Dr. Takasoglu and maybe end with Dr. Underberg here, of what would your closing comments about the importance of lipoprotein A and bringing it into better recognition in medical practice would be. Dr. Takasoglu.
I think LPA is an independent and causal risk factor, which is usually underdiagnosed, not known well enough, and not taken into consideration. We certainly need unified, standardized approaches to measurement of LPA so that the clinicians can base their decisions on it. And I'm hoping to have some significant therapies in the future to treat this, which will make a big impact because LPA is high in more than 20% of the population. And in addition to the medical organization, I think patient organizations also have a role to increase awareness. We certainly need increased awareness, not only in the medical community, but also in the patient community as well.
Wonderful. Dr. Sanchez.
I will echo what's already been said and say not one voice, but one chorus with harmonized voices speaking to the issue of lipoprotein A. I think unifying around measurement, continuing to gather data and perhaps organize ourselves to bring even more clarity to the epidemiology of lipoprotein A and its consequences, and then continue to move towards identifying those therapeutic opportunities to lower risk and save lives.
Wonderful. Dr. Mayer.
I'm just looking forward to, as the research continues, learning more about lipoprotein A and learning more about these emerging therapies. I'm very excited for the future for patients involved in these trials and involved will get these therapies in the future, because I'm very hopeful and very excited about how the future looks towards lipoprotein A. I'm very excited about the ongoing education, and I think we need to continue to focus on the standardization and guidelines in going forward.
Great. Dr. Underberg.
So I wear two hats. I'm a lipidologist, see patients referred for lipid disorders, but I'm also an internist, and I spend part of my time doing primary care and spend a lot of time educating colleagues in the primary care space. And I actually think that a major role for us right now is to translate this information into the primary care space. All too often, when I make a recommendation about screening lipoprotein A in families, the response I hear is there's nothing you can do about it, so why check it? And obviously, as we've discussed today, that's clearly not the case. And so even before we have new therapeutic options available to us, identifying the importance of risk in patients is a key factor to educate those in the primary care space, whether it's physicians or whether it's nurse practitioners or physician assistants or whomever is acting as the primary care focal point for the patient. And I think that's one of the most important things we can do, is if we don't identify patients who have elevations in families, there's not much we can do about addressing their risk.
This has been just a fantastic discussion. I think this is going to, I hope that this will have an impact on everybody who listens. I think back to that day in about 1977 or 78 when Josta Dahlin walked into his new laboratory in Houston from the city of Boden and up near the Arctic Circle in Sweden, and how far we have come from Dr. Berg, Dr. Uderman, and all of those who have brought us this far. The efforts of Samikas and Whitsom in San Diego, and all that you are doing to help us learn about a major cardiovascular risk factor. Thank you so much.